Hello and welcome to Bridging Community, Collaborative Efforts in Early Detection and Intervention for Alzheimer's Disease. I'm Ariel Cole. I'm a primary care physician, family medicine trained with specialty in geriatrics, and I'm program director for a geriatric medicine fellowship with Advent Health in Orlando, Florida. I have some excellent colleagues joining me today, and I'll turn it over to them to introduce themselves.
I'm Ali Atri. I'm a cognitive neurologist. I'm the chief medical officer for Banner Research, and I take care of patients and families with early onset or atypical Alzheimer's and dementias.
I'm Elizabeth Pointer. I'm a gynecologist, GYN oncologist, midlife women's health expert. I'm chair of women's health at Atria Health and Research Institute.
I'm Dr. Anton Thorstensen. I'm trained as a geriatric psychiatrist, and I singularly focus on the care and study of older individuals with memory disorders like Alzheimer's disease. I'm the William B. and Sheila Konar Professor at the University of Rochester School of Medicine.
Our learning objectives for this session are to integrate strategies into care plans that optimize brain health for patients with factors that increase the risk of cognitive decline and Alzheimer dementia, describe the latest evidence supporting the need for the early detection of mild cognitive impairment in the Alzheimer disease continuum, and develop patient-centered communication strategies to address brain health and cognitive concerns with patients and their caregivers. Many patients and caregivers ask me what is the difference between Alzheimer's and dementia. And I explain, as you can see, that dementia is an umbrella term for a variety of disease processes that cause progressive memory loss of memory and other thinking abilities severe enough to interfere with daily life. And Alzheimer's is the most common of those. But there are other causes, including Lewy body, frontotemporal, vascular, and mixed dementia is fairly common as well. There are categories in the cognitive disorders spectrum. We're familiar with patients with early heart failure or chronic kidney disease. The same is true for Alzheimer, in that there are patients who have disease process ongoing without symptoms yet. Those would be in the cognitively normal, and then the disease progresses to mild cognitive impairment and dementia. Alzheimer's disease, as we said, the most common type of dementia, produces significant cognitive impairment affecting social or occupational functioning and representing a significant decline from previous level of functioning. That decline is slow and progressive and has a long pre-symptomatic phase, probably in excess of 20 years. Dr. Alois Alzheimer, when he published about this disease process, identified plaques and tangles. We now know that those plaques represent extracellular amyloid beta deposition, and the tangles are composed primarily of hyperphosphorylated tau proteins.
So Alzheimer's disease has a complex neuropathology. There are multiple mechanisms that come together to contribute to the pathogenesis and the progression. Brain amyloid accumulation is clearly involved, both soluble beta amyloid as well as deposited beta amyloid that forms the plaque. But it is also clearly not the entire cause of Alzheimer's disease. How do we know that? Well, there are multiple pathologies that we see when we look at the brains, but also, even if we are able to fully clear beta amyloid plaques with the new anti-amyloid antibody medications, if we start treatment at the stage of disease, that is MCI or mild AD, we have yet to see this intervention truly improve cognitive function or reverse the cognitive disability. It may slow the disease, but it doesn't freeze it completely. Now, we can also see elevated brain amyloid, especially plaque burden, in the brains of clinically normal persons in post-mortem studies. So there are other pathologies that travel alongside the amyloid. One of the best known is the hyperphosphorylation of the tau protein. And that has its own impact. It's probably connected to the elevation of beta amyloid that triggers this cascade. But we know that tau protein is damaging to neuronal structure and functioning, leads to cell death, and actually is in some ways closer connected to clinical decline than what we see with amyloid. And now tau interventions are actually an active part of clinical trials, be that antibodies that target especially the MTBR forms of tau, but also kinases that stop the hyperphosphorylation of tau. As you heard earlier, Alzheimer's disease is a complex disease with a complex pathogenesis. Reflecting that, diagnostic criteria have changed over the years. And with the advent of biomarkers, and those biomarkers are both fluid biomarkers, increasingly blood, but also cerebrospinal fluid, in addition to the imaging biomarkers that we see with PET scans and MRI, in 2018, Alzheimer's disease actually given a biological definition. And that is that in order to have Alzheimer's disease, you needed to have elevated beta amyloid, tau pathology, and neurodegeneration. This was further expanded in August of 2023 when the NIA-AA definition was updated to use the most well-validated biomarkers.